APGO educational topic number 29, anxiety and depression. Here is our patient, Labora Deliverich. She has had a successful pregnancy, labor, and delivery. She has a beautiful new baby and feels that she's supposed to be very happy to start this new chapter of her life. But depressive symptoms are very common for women in the postpartum period. There is a confluence of hormonal shifts, major life changes, and extreme sleep deprivation that can contribute to the development of mental health concerns. The objectives of this video are to list risk factors for postpartum blues, depression, and psychosis, differentiate between postpartum blues, depression, and psychosis, compare and contrast treatment options for postpartum blues, depression, and psychosis, and recognize appropriate treatment options for mood disorders during pregnancy and lactation. Postpartum blues are extremely common. Approximately 70 to 80% of women report feeling sad, anxious, or angry beginning 2 to 4 days after birth. Postpartum blues is characterized by tearfulness, fatigue, irritability, depressed affect, mild insomnia, and is usually self-limited and usually does not require any treatment. Postpartum depression, on the other hand, differs from postpartum blues in the severity and the duration. It is defined as a major episode of depression that occurs within the first 4 weeks or within the first 6 months postpartum. The incidence of postpartum depression is 10%, and it is characterized by pronounced feelings of sadness, anxiety, and despair, and interferes with activities of daily living. And the symptoms tend to worsen with time. Treatment for postpartum depression is with antidepressant therapy and/or psychotherapy. Postpartum psychosis is the most severe form of mental disorder in the postpartum time. It is characterized by confusion, clouded sensorium, and distractibility. Treatment is with antipsychotic and/or antidepressant medications. Let's now move on to risk factors for these 3 different conditions. Risk factors for postpartum blues include psychosocial stresses such as childcare or psychosocial impairment, a history of depression or a family history of depression, depressive symptoms pre-pregnancy or during the pregnancy, and a history of hormonally sensitive mood changes such as premenstrual syndrome or mood changes with oral contraception. For risk factors for postpartum depression, having a history of depression is the most significant risk factor. Psychosocial stresses are also significant risk factors. A history of physical or sexual abuse, being young, this being an unplanned pregnancy or thoughts of terminating the pregnancy, a lack of social and financial support, living without a partner, intimate partner violence, or stressful life events such as a marital conflict during the 12 months prior to delivery. The most significant risk factor for postpartum psychosis is pre-existing mental disease such as bipolar disorder or schizophrenia. We will conclude this video by discussing treatment options for mood disorders during pregnancy and the postpartum period. There are over 500,000 pregnancies in the United States that involve women who have psychiatric illnesses that either predate or emerge during the pregnancy. An estimated 1/3 of pregnant women are exposed to psychotropic medications at some point during pregnancy. Simply advising women to stop could lead to untreated maternal psychiatric illness, which could lead to poor compliance with prenatal care, inadequate nutrition, exposure to additional medications or herbal remedies, increased alcohol or tobacco use, deficits in mother-infant bonding, disruptions within the family environment, and pregnancy complications such as premature birth, low birth weight infants, fetal growth restrictions, and postnatal complications. All psychotropic medications do cross the placenta, are present in amniotic fluid, and can enter breast milk. The general treatment concepts include that optimally there should be shared decision-making among obstetricians and mental health clinicians, and a single medication at a higher dose is preferred over multiple medications. Changing medications also increases the exposure to the offspring. Let's now move to safety and efficacy considerations for depression during pregnancy. Most of our data is on SSRI use during pregnancy, and there is limited data on the teratogenic effects. There has been concern about increased risk of congenital cardiac malformations with first trimester paroxetine exposure, so it is generally advisable to avoid paroxetine in pregnancy. There is currently conflicting data on SSRI exposure during early pregnancy and risk of both overall and specific malformations. Exposure to SSRIs late in pregnancy has been associated with transient neonatal complications such as jitteriness, mild respiratory distress, transient tachypnea of the newborn, weak cry, poor tone, and neonatal intensive care unit admissions. The use of lithium for bipolar disease has been associated with a small increase in the congenital cardiac malformation of Epstein's anomaly. For breastfeeding, the amount of medication transfer is lower with breastfeeding than with transplacental exposure. There are a few isolated cases of adverse events that have been reported, although infant follow-up data is limited. With breastfeeding and with pregnancy, careful consideration should be given to our patient's overall needs and wellness and how best to optimize the balance between the risks of medications with the risks of not treating her mental health needs. This concludes the APGO video on anxiety and depression. We have discussed postpartum blues, depression, psychoses, as well as recognized appropriate treatment options for mood disorders during pregnancy and lactation.